Assalamu alaikum. The clinical, long clinical day. The first scenario, Mr. Sam Adam, 45 years old man, presented with palpitation. His blood pressure 155/90. Pulse rate is 110. Serum potassium 2.9. Please take history, examine the patient, and address his concerns.
Hello,
Yes.
Hello.
my name is Dr. Marwa, one of the doctors in the clinic today. Can I confirm you are Mr. Sam and Adam,
Yes.
45 years old?
Yes, doctor.
We are here, Mr. Sam, to discuss with you some issues related to your medical condition. And also, I am going to examine you. Is it okay with you?
Yes, doctor.
Can you tell me how can I help you?
Actually, doctor, I feel my heart is racing in the last few months.
In the last 2 months?
Yes,
It starts suddenly or gradually?
gradually, doctor.
Any specific time you feel this heart racing?
No, no specific time.
All over the day you feel this heart racing?
What?
All over the day?
What you said?
Do you feel this specific position or specific
No
effort?
specific. No specific time of the
You,
day.
you feel this heart racing regular, like clock, or irregular pattern?
Yes, regular. Yes, regular. Yes.
Is this racing associated with shortness of breath or chest pain?
Yes, when this episodes come, I feel shortness of breathing, even at rest. Yes.
This episode lasts for how long? When it's come?
It lasts. Every episode lasts about 10 minutes like this.
Yes. Is it associated with any weakness in your legs or arms or any part of
No.
your body? No.
I feel my body. All my body is weak. But during these attacks, no increase in the weakness because I'm only concerned with the heartbeat.
You feel your body is weak, but you didn't concern of this.
Yes, during
Right?
this attack. Yes,
Mm.
during this attack.
Did you notice anything increase these attacks?
Like what? Yeah.
Like specific type of meals, like effort,
No,
anything relieve these attacks?
nothing, doctor. It come. It's own and it go and not expected. This it's not expected.
Okay. Is this the first time you suffer from these attacks from 2 months? Is it the first time at all?
Yes, 2 months. Yes, 2 months. Yes, 2 months.
What happened before this month?
No, before I feel weak and my muscles are weak also, but this palpitation or racing of heartbeat is recently developed.
Okay, this week when started this weakness?
This weakness for a long time, about 2 years now.
Do you feel any difficulty in walking or climbing stairs?
Yes,
Or
yes, I feel weak.
you
I
feel
feel all my muscles are weak. Yes.
you feel any difficulty in lifting heavy objects?
Yes.
Or,
Yes.
any change in your weight?
No, my weight is okay.
You have any long-lasting condition?
Long what?
Long-lasting condition or illness like
Yes,
high blood
yes,
pressure,
yes.
high blood.
Yes, I have high blood pressure, and actually it is difficult to control really.
Since when?
Long time, about 10 years now, I have this blood pressure rising.
What medication you take for this blood pressure?
Actually, doctor, every visit I go to my doctor, he found my blood pressure is not controlled. He changes the medication. Every while he changes the medication. One time, Cabotin, one time, Telmisartan, one time beta blocker, like this.
Tell me the last medication list you have.
About 6 months now, I take medication named Labetalol.
Labetalol? Only labetalol now you have?
Yes. Also, hydralazine was started also for me.
Any other thing in your medication list?
No. Sometimes painkiller only.
Painkiller for what?
For this muscle ache and bone ache, like this. Headache.
Okay. And no other medication other than this hypertension?
Yes, I don't have any other medication.
Yes. Uh, you have any headache?
Yes, sometimes I feel headache yes, because of this blood pressure. My blood pressure sometimes it reached about 165, 170 like this. At that time I feel headache and I take extra dose of the blood pressure decreasing medication and I take also painkiller.
For this headache?
Yes.
Is this headache associated with any feeling sick or throwing up?
No.
Or blurring of vision?
After blood pressure improve, headache improve also. Second day, headache improve also.
Yeah. Do you have any weather intolerance?
No.
You said you didn't have any weight change, right?
No weight change.
Okay. Do you have any abnormal sensation in your legs or arms?
No.
Any loss of consciousness or
Any what?
a loss of consciousness or your consciousness or
No.
fainting?
No.
Any change in your vision or your hearing?
My vision is okay. My hearing also is okay. But I think when these attacks of palpitation came and racing of heartbeat, sometimes I feel dizzy at that time only. But otherwise, no dizzy. No dizzy.
Do you feel any sweating or
No.
hand shaking?
No.
Okay. Do you feel any tummy pain or bloating, swelling in your tummy?
No.
Any change in bowel motion?
No. My bowel habit is okay.
Any change in your water work?
No. My water work is also normal.
No change in frequency, color, pain?
No. My
Okay.
water work is normal.
Any swelling in your legs?
No swelling in my legs.
Okay. What do you do for a living, Mr. Sam?
I am accountant.
Is this symptoms affecting your work or with your daily life?
Really, yes, doctor. Along about 2 years now, I feel weak. My all muscles are weak. And the recent 2 months back with these frequent attacks of palpitation, and I feel about to die. So it affected my job, and my performance also is decreasing.
I'm sorry for all of this suffering, Mr. Sam, and we are here to help you and supporting you as much as we can.
Thank you, doctor.
Do you smoke or do you smoke?
I smoke. Yes, I smoke.
How much for how long?
1 packet per day for about 1 year now.
Mhm. I highly advise you to stop smoking because you are heavy smoker and it's affecting badly your health.
Okay, doctor. I will consider this.
Do you drink alcohol?
No, only social at the weekend with my friend like this.
Can I examine you now?
Yes, okay.
I want to measure blood pressure sitting and standing. Yes.
It is the same sitting and standing. It about 160 now by 100.
Uh, I will the pulse 100. The eyes that short
Now pulse is 90. Okay, what?
and regular
Regular, yes, regular.
equal in both sides.
Yes, equal in both.
I need to examine lower limb for tone, power, reflexes.
Neurologically normal. Tone, power, reflexes normal.
Sensation,
Sensation intact also.
coordination.
Also intact.
And upper limb but also tone, power.
Yes, okay, normal also.
Okay. I will
Yeah.
examine chest for auscultation for
Yes.
chest and heart.
Just
Heart,
clear, heart, no murmurs
heart,
also. No
الهارت
murmurs. No
no
murmurs.
murmurs الابيكس and its normal size.
Fifth intercostal space mid clavicular line. No special character.
Thyroid,
Thyroid,
neck for thyroid and lymph nodes.
no neck swelling. No lumps and bumps. No lymph nodes.
I will examine hand for any tremors.
No tremors.
Okay. Body mass index for this session.
24.
What's your concern, Mr. Sam?
My concern, doctor, is this palpitation or racing of my heartbeat? It is related to this my rash?
Rash?
Yes.
What rash?
I will send it to our groups, okay?
2 minutes left. And the bomb in the meeting now.
Okay, in the WhatsApp group, okay, doctor?
Okay, I will send it to you.
When this rash appear?
This since my birth, I see this rash, but it is increasing with time. It increases.
Where is the site of this rash?
This rash in the back. You see it?
Only in the back? Only back?
This picture taken from the back of the patient, yes.
But the rash all over the body or only in the back?
Present in front and behind, also, yes. In the trunk, anterior and
It's
posterior.
blanchable or not blanchable?
Not blanchable.
Any pain in this rash? Any itching?
Not painful, no, not painful.
Any itching?
No,
Any discharge from this rash?
No.
It's since your birth, your usage.
Yes, for long time really, but
Is this condition in any other part in your family? Other one in your family?
every year it will
Anyone in your family has the same condition?
Yes, my
Hmm?
father have the same rash.
The same rash, and his blood pressure also increased.
Yes, and my father also is hypertensive and he on medication also.
Did your father have any diagnosis, non-diagnosis?
Yes, he has this rash and hypertension.
Is he diagnosed by any disease?
Yes, he is diagnosed with neurofibromatosis with hypertension.
Okay, time is up. Dr. Mahi, you can start.
لها 1 minute for
Okay,
concern.
no worry.
Dr.
Okay, address the concern.
What's your concern? Yeah, Mr. Sam.
Yes, I asked you, Doctor, is this rash related to this racing of heartbeat?
Um, I think yes, Mr. Sam, this rash and all symptoms you have is related to each other by some way.
So, what you will do with me,
But we
Doctor?
know we need to run some blood investigations to reach to proper diagnosis. We need to admit you and run some investigations and control your blood pressure.
Okay.
And
Okay, Doctor.
Okay, before the examiner question, what else you want to examine after you know the rash now? What else you want to examine on the patient?
abdominal examination, I missed abdominal examination.
Looking for what?
Any organomegaly, any
What
kidney,
specific organ you want to examine?
kidney.
Perfect. For ballotment, you mean, right?
Yes.
What else you want to do? Over the kidney.
Auscultation for Bernoulli, for renal artery stenosis.
Perfect. That's enough. Okay. Examiner question, Dr. Mohi, please.
Yes, Doctor, can you present the positive finding in this 45 years old male patient?
This is a middle-aged male patient with attacks of hypertension or weakness, uncontrolled blood pressure, hypokalemia with also he complains from skin neurofibromatosis, skin lesions in his back. He on multiple medication for blood pressure and not controlled.
Yes. What is the cause of his palpitation now? What is the cause of this palpitation? Why he is
Palpitation, maybe I have pheochromocytoma may explain this hypokalemia and attacks of palpitation, hypertension.
Where is the evidence of pheochromocytoma in this patient?
Hypokalemia.
What is the evidence
Hypokalemia.
What is the evidence of in the history indicates this patient has
In history, yes, he said this symptoms comes in attacks of weakness, dizziness, palpitation, or hypertension.
He told you the weakness is long time and did not in episode. So the episode is only in racing of heartbeat. You ask about checking
Yes.
of the he said no.
He's mm,
any anxiety, any sweating, any thoughts? No, no, no. So no
mm,
evidence of episodic flushing or sweating. Or you still
mm.
suspect a chromocytoma after he denies this in the history?
And it's put in differential, but
Okay, you can put it in differential, yes, but not number one. Okay, what else? Why patient has hypokalemia also? Why patient has hypokalemia?
hypokalemia. His medication. hypokalemia maybe cons أو Cushing, but no يعني for Cushing no against this no weight gain, no signs of Cushing. Maybe cons.
Okay. But maybe يعني it is a part of the neurofibromatosis. Cons is a part from neurofibromatosis.
Neurofibromatosis. I don't know. It's part or not part. Adrenal adenoma maybe يعني
Associated.
associated with
Okay. So reach to the renal adenoma. What the investigation you will do?
I will start by
To reach to
the
the
basic
yes.
to reach to diagnosis. We need to measure renin and aldosterone level to notice primary or secondary hyperaldosteronism.
Yes.
We need to do imaging for adrenal gland, CT, abdomen, or MRI.
From the start, you know, يعني steps you should go step by step, صح? You will go direct to MRI.
First, ultrasound. Ultrasound.
What do you expect in ultrasound testing?
Ultrasound, if renal artery stenosis may show decrease difference in size in both kidneys. If there's renal artery stenosis or Doppler
Yes.
on renal
Yes.
artery.
Okay, you expect this patient has renal artery stenosis or no?
Yes, may have renal artery stenosis with
Why?
uncontrolled blood
Why?
pressure.
Yes, what else? What else?
Also medications, in his medication no ACE inhibitors. He start on Capitan, then stops. Huh? You
Yes.
say it like this? I
Yes.
think Capitan in this case will increase the renal impairment. Then he shift to labetalol وهيدرولازين.
But the patient has no renal impairment in the history or يعني laboratory, no renal impairment. Let's say.
From history يعني from history his medication list. Maybe يعني.
Okay. So how you will manage this patient, doctor? How you will control him? He came because not of blood pressure. He came because of palpitation. So how you will manage this palpitation?
Palpitation. I think we give him if it is في chromocytoma or give alpha blocker before beta blocker.
Yes.
صح? But we need to confirm diagnosis
If
first
not,
and
if not pheochromocytoma, and the case is not pheochromocytoma.
we need to correct the hypokalemia also and do ECG.
Okay, doctor. Hypokalemia is the direct cause of this palpitation. It's causing arrhythmia to the heart, and it is fatal hypokalemia. So we will correct hypokalemia. Last question: if this hypokalemia is resistant to treatment, what do you expect? If you give potassium chloride IV.
Expect hypomagnesemia associated with.
Very good. Yes, very good. Very good. اوكي دكتور باسم، حضرتك لو عايز تكمل يعني اوكي.
You mean question?
اللي أنت شايفه يا باشا.
Yes, I want to add some question.
Okay.
She said the pharmacological only, right? Any role to other management plan in this scenario, Dr. Marwa?
You mean I don't know. Yeah, what's the diagnosis? I don't know what is the diagnosis in there.
Okay, you don't know and you saw something related to other system, which is the skin. So the
Yes,
first
no.
the first thing in your management plan, what is it?
الECG والcorrection electrolyte correction.
No, this is for investigation. I'm talking about the management plan. You have now kidney problem, right? Renal affection, skin, and you might have endocrine. What you do? You manage
اللي
all
هي
this alone?
multidisciplinary دي.
Exactly. Always start with this. Don't give the pharmacological option only. Yes, your answers is correct, but you will not manage this patient alone. He has a lot of systems affected. Started by the skin, the kidney, endocrine, and even genetic, right? You suspect a genetic condition.
Yes.
Neurology also. You have to consider neurology if it is type 1 or type 2, and you didn't screen for this. Don't start a management plan without mentioning multidisciplinary team. It's
Yes.
very necessary to put them in the first answer. How to manage this patient? I will start with multidisciplinary team approach. Then mention what are the multidisciplinary team approach. Okay? Okay, I think that's enough for the questions because we have a lot of comments. I think the case is still missing something. So we have to listen, Dr. Mahi, then I will comment.
I want only to comment about approaching for patient with a palpitation because this is very broad term in basis. Endocrine causes can cause, heart disease can cause, hypoxia can cause, pulmonary embolism can cause. So first I will take the palpitation itself and I will take analysis about this. This is first time or no, onset, course, duration, what increase, what decrease, what association, is there any syncope, pre-syncope happen, any dizziness, situations during this palpitation, do you can cope your daily activity or you what about the rate it reach how much like this, any ECG done during these attacks, any holter done like this to know. Then I will ask about the heart, any previous history of the heart, any heart attack before, any hereditary heart in the family, any sudden cardiac death in the family. Then I will ask about symptoms of heart failure and chest pain like this. Then I will go to the endocrine and I will take endocrine because it is mostly related. Thyroid. I will screen for thyroid, for pheochromocytoma 4. Then I will, all these are negative, negative, negative. No heart problem, no endocrine problem. Then I will go to the scheme with structure history. Well, do you have any joint pain, any skin rash, any? It maybe give me any clues. Yes, I have a skin rash. Show me. Oh, it's neurofibromatosis. And what is neurofibromatosis? What is the relation between neurofibromatosis and hypokalemia? Yes, this patient has hypertension also, and hypertension is uncontrolled and so the two possibilities of uncontrolled hypertension with neurofibromatosis are pheochromocytoma and renal artery stenosis. I ask in the history while I'm going to about endocrine, any episodes of flushing, any, no. Okay, then this is renal artery stenosis. I know this renal artery stenosis, it can cause hypokalemia, but by a mechanism, renal artery stenosis activates the renin, angiotensin, aldosterone system, so it will increase aldosterone. Increasing of aldosterone level, it will cause hypokalemia. So this is the cause of low potassium. I also ask about the patient, do you have hypertension and what is the medication? Maybe medications have diuretics and diuretics cause low potassium, but it is already excluded when I told him, show me your medication list. So this patient has renal artery stenosis. I should examine about neurofibromatosis because not only neurofibroma is the diagnostic. I will see shagreen patches, coffee oily spots, and freckling in the axillary like this. I ask about vision. Dr. Marwa already asked about vision. Any blurring of vision because optic glioma can be. Any hearing must be, even neurofibromatosis type 1, it can cause hearing loss or impaired hearing. So I diagnose the case now is neurofibromatosis by history and examination of the skin, any epilepsy, any loss of consciousness before any. Then I will go to examine while I'm examining the skin because I want to, maybe the examiner ask me what are the criteria now to say this is neurofibromatosis. And then I check blood pressure, I ask about, then I will go to the abdomen, I auscultate for any berwi. Then if I did not hear berwi, I will tell the examiner that I will do ultrasound. Possibly ultrasound can cause يعني asymmetry of the kidney size between the left and right. And this is, and Doppler also can be to detect if this is renal artery stenosis. Also, Cohen's disease can be associated. يعني patient, maybe patient has neurofibromatosis and has also Cohen's disease. But the more يعني near to the diagnosis is renal artery stenosis because the patient has neurofibromatosis. But this is my comment about the case. This case came before على فكرة in Date 324. Okay.
Yes, it's common case as association with neurofibromatosis. Don't forget pheochromocytoma itself can be as an association to neurofibromatosis plus von Hippel-Lindau. And I think coarctation of aorta also one of the association, right? So it would be also one of the causes of hypertension, but it would be differentiate hypertension or in the upper limbs, not in the lower limb. So in one of the exams, she should ask about radiofemoral delay. This is regarding the possible association. But let's start, as Dr. Muhi said, what the cause of palpitation in paces. And he mentioned a lot of them. On the top of them, the cardiac cause. Simply, palpitation as cardiac, you should analyze the heart or cardiovascular system. Dr. Mar was asked about chest pain. I'm not sure if she asked. Chest pain?
Yes, I asked.
Perfect. So you ask the relevant system, which is
Yes.
very important. If you have chest pain in this scenario, what do you suspect? Before moving forward.
Means ischemic heart due to hypertension.
Perfect. The best answer. Chest pain, and especially with the exercise, with the arrhythmia, means ischemic heart disease complicated by arrhythmia. Simply, and it might be the case, by the way. But you will do the analysis of other systems. But I mean, you have to put it in your mind. Differential, palpitation, heart disease is the top of them. Okay? This is the first, as a cardiac. This is how to analyze the palpitation. The second possible cause, as Dr. Muhi said, the hypertension, or sorry, it would be associated with the endocrine system, and it's also common in paces, pheochromocytoma, thyrotoxicosis. Both of them can cause palpitation, and it's very common. You have to screen for them. The thyroid, you will ask by any intolerance to the weather, and Dr. Maro also covered it. But if you go through the history as a systematic, organized way, after asking the relevant system, analyzing the palpitation itself, the good thing Dr. Marwa here asked about constitutional symptoms. Why? To rule out any serious condition. And pheochromocytoma, by the way, and thyrotoxicosis, it would be associated with loss of weight, right? So you can narrow your diagnosis when you ask this question. Constitutional symptoms plus palpitation, I mean loss of weight or with preserved appetite, it might give you clue for hyperthyroidism or pheochromocytoma. We will not screen now. Sorry.
Weight gain also for Cushing.
Okay, weight gain in the other arm, yes, it could be as Cushing, and the Cushing as well would be associated with hypo.
hypertension وhypokalemia.
Exactly. Okay, now we'll go to the next analysis, which is the system review. What do you think the systemic review will help you in this scenario? Perfect, it will. Why? When you start with the CNS, you will find the headache, and the headache will be positive in pheochromocytoma. It would be positive also with thyrotoxicosis if there is anemia, for example. And coarctation of aorta, it would be also there. The good thing, Dr. Marwa analyzed the headache. Any alarming sign of the headache, increase in tachycardia pressure? No, it's headache related to the hypertension. Now the analysis of the CNS, because we might have other finding like vision problem for papilledema due to hypertension, or even hypertensive retinopathy. It might be there. Good thing she asked. And for neurofibromatosis, it would be associated with optic glioma, right?
Also schwannoma والhearing loss with
Yeah,
neurofibromatosis.
we didn't go now to the hearing, but I'm talking about the vision. Also, I think Lish nodule here in the neurophytomas, right? Neurofibromatosis. But it's not affecting the vision. The thing affecting the vision is optic glioma. Okay, let's move to the hearing, as Dr. Marwa said. For hearing problem or unsteadiness, this is for the type 2 neurofibromatosis, schwannoma, or any cerebropontine angle tumor. Clear?
I think optic glioma and type 1 والschwannoma and type 2.
Yes, optic glioma and type 1. That's why you have to ask for the cranial nerves or the manifestation of brainstem, unbalance or unsteadiness, and the hearing. And also, I think what else in the cerebellopontine facial, I think, as a compression, but it's not the case. So hearing and the balance. Okay, still we are in the nervous system. We are either rolling out or rolling out in the manifestation, and already we get two of the manifestation, which is the headache. It would be related to the hypertension, and optic glioma related to neurofibromatosis, type 1 particularly. We will assume this case is type 1, but you have to screen for type 2 as well. The next question or the next system to be asked here, the weather or the endocrine, about weather intolerance, to roll out or to roll in thyroid. If you rolled out thyroid, so you can remove the thyroid as a cause, hyperthyroidism. But still one of the differential, by the way. It might be the case as a differential diagnosis to this scenario. Next, already we analyzed the cardiovascular. Now we'll analyze the chest. Any short of breath or cough? You have to ask this question. It might be there if the patient is hypertensive. He might have attacks of flash pulmonary edema, for example. Particularly the renal artery stenosis. It's very important to roll out any previous attack of severe hypertension that would lead to pulmonary edema, hypertensive pulmonary edema. And he might give you a history of hospital admission to the CCU or to the ICU for non-invasive or medication like nitroglycerin to control the blood pressure, which is the cause of hypertensive pulmonary edema. We finished the chest. Now we will go to the tummy or abdomen or GI. Any difficult swallowing, it's not there. You can ask about any discomfort or abdominal pain. It wouldn't be there. Change of the bowel habit. What do you think, Dr. Marwa? Any associated change of the bowel with this condition might be?
الهايبوكاليميا ممكن تعمل paralytic areas constipation.
Perfect. This is as a cause of or as a sequence of the hypokalemia. What about the condition that lead to change of the bowel habit? Pheochromocytoma. Any change with it?
Yes, maybe area.
Yeah, so it
area.
might be there. Okay. Then the genitourinary, already asked by Dr. Marwa. Any
Even
change of...
Dr.
Yes.
Basim, in my exam, it came with bloody diarrhea, actually. It was a blood stool. This is the complaint. So I've been asked about the differential diagnosis of bloody diarrhea in neurofibromatosis. So I think it be like neurofibroma in the colon or colon cancer, or it could be infection. I think this is the differential, but I didn't hear about that before in
Yeah,
this
me
bloody
too. This
diarrhea.
is first time. Bloody diarrhea
So
as a
yeah.
three chromocytoma or with
Yes,
Yes.
neurofibromatosis.
neurofibromatosis. The case is very clear. The patient, even in her face, there is a neurofibroma, very clear. So,
Uh-huh.
but the complaint was bloody diarrhea. So I just say that, and I think it's going well here.
Okay, good. Good to know. First time, but in basis it
Yes.
happened.
Yeah, actually, I'm shocked. I didn't answer. In the first, I told him that I don't know the relation between the blood diarrhea and neurofibromatosis. But then he told me, "What do you think?" So I said that, and I think it's good.
Okay. That's good also to know and to hear about it. We can search also about it. Someone can search and update us. Thank you, Dr. Samir. It's good to know. That's why we are here in this meeting. Any experience you can share with us, it might be unique, but it might be as a first time, then it will be again happen with anyone. So we will gain this information from us or from each other. Okay, thank you, Dr. Samia, again. Let's move to the genitourinary already explained what association might be there. Yes, it might be associated with the might be renal impairment, particularly renal arteriostosis as a pre-renal, I mean. It might lead to frothiness or even decrease urine output. But it didn't happen here. The next system, Dr. Marwa missed, and it was like essential, and it was the magic, and it was shocking to hear the question at the end. The musculoskeletal. I don't know why always we are missing this system. Musculoskeletal is very important. Any joint pain and skin rash. It will help you either if there is like this patient skin rash, it will help you to know the case. If you miss it, but I believe in the exam you might know from the face, as Dr. Samia said, from his face or the patient face, but don't depend on the face only. It might be in the back, and he will hide, of course, his back. He will not show you his back unless you ask him. So if you miss this as a question in the systemic review, you will miss the case and you will miss even the examination. You will not ask him to expose his back or axillary freckling. You will not know this, right? But if you ask
Yes,
any
Dr. Bassam, even actually in the back, he has like some deformities in the back. So unless we ask to check the back, we will miss this deformity.
exactly,
It's
yes,
very clear. Yeah.
that's why the systemic review, believe me, because I hear some mentors saying, no, it's not important to ask all the question of systemic review. It's unnecessary. But for me, you will not gain this information unless you ask specifically about every system. You will not guess about a skin rash in this patient unless you ask it in the systemic review. You are talking about hypertension, palpitation, shakiness of the hands. You might suspect fucocytoma, and totally you forget the neurofibromatosis. So it's important to ask. This is my opinion again. Let's move forward to the other systems. Female or male system you can ask, but I believe in this scenario it might be not there. I mean, any change in the desire or any change of his intimate relationships, but it might be also affected because of some medication. For example, if this patient is taking beta blocker, it might be there, right? Labetalol or bisoprolol or metoprolol might affect the intimacy, or it can cause some impotence. So this system sometimes is important as a female, and sometimes in male, like diabetes, you have to ask about autonomic neuropathy or medication or diabetes itself. In the long term, it might lead to impotence. So you have to ask about the intimacy either here or with the HIV question. Do you have any casual relationships? And at the same time, you can ask about his intimacy. What Dr. Marwa missed here, and she remember at the end, the family history, which is also crucial, important. Any family history of the same condition? Yes, my father was having hypertension, my father was having skin rash, my father was having vision problem, my father was having and he give you the case. My father was diagnosed as new fibromatosis. But don't wait for him in the exam to tell you his diagnosis. Dr. Mohi, of course, he was kind to tell you, but it's not necessary. The surrogate will tell you, yes, my father was diagnosed as. He will not tell you, because if he told you, you will know the case. Anyway, will not wait for this information from the patient or from the surrogate, but hopefully they might tell us. But once you see the skin rash, you will know the case. This is regarding the family history. Travel, it's not the case here. HIV question, I think this is not a case of suspicious event for HIV. And then you can ask about, do you smoke, do you drink alcohol, what's your job? And driving, important here to ask about driving, right? If there is a vision problem. Finish that, you will go for examination. Dr. Marwa, I think, did all steps of examination. But the freckling, the axilla, you didn't expose, Dr. Marwa, right? And you can offer slit lamp, and you can offer also long bone. It's one of the criteria, right? Deformity in the bones or sarcomas. It's one of the deformities. So what are the 7 criteria for neurofibromatosis, Dr. Marwa?
7 countries.
Sorry?
I can't remember. No.
Yeah, coffee ole, right? Neurofibromatosis or neurofibromas. Coffee ole, there is criteria for coffee ole, by the way, right? The measurement 15 millimeter,
Yes, more than
more than
6.
6 and 15 millimeter, right? This is first criteria. Axillary freckling, neurofibroma multiplex.
Yes, 1 multiplex or 2 neurofibroma عادية يعني.
Yes, okay, 1 multiplex, which is big, complicated one, complex. It's like, yeah, skin extra or skin area. I mean, it's like appendix or something outside the body. It's big in size. Okay, this is the third criteria. The fourth criteria, leash nodule, right? Leash,
Yes,
which
yes.
is by the fundus, sorry, by slit lamp. Then the family optic glioma, family history, and bone deformity.
لونج بون ايوه لونج بون بيبقى
Long
فيها
bone.
ايه بقى؟
Like sarcomas or deformity, tumors. Okay, 3 out of 7, it's diagnostic criteria, or it's meeting the criteria. So you can diagnose by this finding. 3 out 7. We can repeat them again. Skin as a skin rash, coffee ole, more than 6, 15 millimeters in size. 2 neurofibromas or multiplex. 1 optic gliomas. So before the eye, the freckling, this is the third. The eye, optic gliomas and leash nodule. Now we have 6, and the family history, sorry, 5, family history 6, and long bone deformity 7. 3 out of 7 is diagnostic for the disease, or are diagnostic. And by the way, you have to examine all of these once you find the neurofibromatosis in the skin. Dr. Samia, give us your experience. What did you find in that patient, please?
Actually, the examiner is not allowed me to examine a lot because she, I think, has some pain in her abdomen. So because the complaint was bloody diarrhea, I started with the abdomen directly and checking for any organomegaly or like also associated, I think, with polycystic kidney disease. So but he tell me خلاص يعني just stop because the patient in
Yep.
pain.
Okay,
So just I told him I want to check for the
perfect.
eye and check for even the cardiovascular examination. And but it was very quickly. He told me just tell me and خلاص يعني. Then
Okay.
we went to the next step. Yeah, but the patient very clear neurofibromatosis from the face, starting from the face and all her body, the back. There's deformity.
Mhm.
The cafe oil is very clear. So I think all the findings is there, but
Yes.
I didn't check very well because it's not allowed. The patient was in pain.
No problem. It's
Yeah,
good, and your luck also that patient is in pain. Because if the patient is calm, you have to examine all these things.
exactly, exactly.
Yes. Okay. Uh, you mentioned polycystic kidney. I think polycystic kidney is associated with tuberous sclerosis, and
Oh,
our case, yeah,
uh-huh. Okay.
neurofibromatosis, yeah, as associated with renal artery stenosis.
Yeah, yeah. Okay, I just think about that. I didn't mention and
No, no, it's okay. You can
yeah.
think about it, but it's not the case.
Okay. Yes,
Okay.
okay. Great.
The examination as Dr. Marwa did, and I particularly ask here any tummy examination or abdominal examination, you have to examine for renal artery stenosis by auscultation for the Berwi. Otherwise, the other steps of examination you have to do, the pulse is very important here to examine and to specify and to comment on and to compare radio between both radial, and you can offer between radial and femoral delay for coarctation as association as well. I think this is the comment about the performance. Knowledge-wise or investigation-wise, Dr. Marwa, remember always to say general, specific, and bedside. Let's start by general. What's important in the general examination, or sorry, investigation in this patient?
General baseline investigators the renal kidney function والCBC.
Perfect. What do you expect? Give me expectation about, for example, kidney function.
Kidney function may be impaired due to uncontrolled blood pressure, maybe high creat,
Perfect.
urea, electrolytes also.
Perfect. And
It's
ultra, you
inner.
have to mention all electrolyte. This is our, or these are the general investigation. What about the specific investigation in this scenario?
specific الرينال دوبلر والابdominal
No, no,
ultrasound
I didn't talk about image now. I'm talking about investigation. Very
investigation
important investigation. You mentioned it, by the way, renal.
ايوه الرينال والالدوستيرون ليفل.
Perfect. Renal aldosterone ratio. Was it helpful?
يس عشان نشوف برايمري والسكندري
Perfect.
هايبر
And in this scenario,
الدوستيرون.
what do you expect?
هذا السيناريو
This is
لو
primary
هي
or secondary?
برايمري لو هي
Why? It's not primary. Primary means in the suprarenal gland, right?
لو هي
This,
كروموسيتوما أشوفت صبراني.
he said this is a case of pheochromocytoma, or he said renal artery stenosis. I think he said, Dr. Mahi, you said renal artery or pheochromocytoma?
هنا
Yes.
الأرتس.
Anyway, pheochromocytoma, yes, it might be as primary, but renal artery stenosis, it would be secondary. So you will have renal aldosterone ratio will be high.
نورمال.
No, high. If the secondary, normal. If primary, yes, high. Yes, you're right. Okay. What else in the specific? For pheochromocytoma now. For pheochromocytoma. Metanephrine, right? Blood and urinary.
يس
This is specific. Okay, what's specific for neophromatosis? Neophromatosis or neophromatosis. What the specific test also? Important. And it's one of the team you should counsel. Genetic.
يس
Neurofibromatosis. What the mode of inheritance in neurofibromatosis?
autosomal dominant.
Yes. So it's you have to counsel about genetic and after screening. Okay, this is regarding specific. What about bedside test? And Dr. Mohi mentioned and helped.
ECG.
Yes, perfect. ECG and urine dipstick.
And
Okay. The last thing, the image. Yes, you mentioned you will start with.
abdominal ultrasound وrenal Doppler
Yeah,
وبعد كده
ultrasound Doppler
CT.
for the renal artery.
مم.
And for the more advanced image, what you will do?
CT abdomen or MRI
CT only or what? What's called?
contrast.
CT angio. Vessels. Any vessels, CT angio.
Yes.
Okay, any vessels, CT angio. But for the fucomcytoma, CT with contrast or suprarenal. CT
Mm.
for suprarenal gland. I think this is my comment regarding the topic itself. Any comment or suggestion from others or any point missed by us? I think there is a
في
lot of yeah.
في الكريتيريا بتاعت النيوف هي النيوروفايبروماتوز انفليكسي فورم. How examine this? ما في صورة.
It's like some patient having not nevus. It's something outside the body like زايدة حتة جلدة زايدة كده جلدة زايدة.
Where?
Everywhere, anywhere.
Any type or
Anywhere.
one plexiform.
Yeah, one.
يعني two
I
or more
wish.
neurofibroma of any type or one plexiform neurofibroma.
Yes. Yes.
How to examine this or I can't understand this.
You will touch it. You will examine the sensation over it. That
Oh,
like this.
the lesions itself يعني
Yeah, the lesion
like in
itself.
this
Yes.
picture.
Yeah.
Okay. فليكلينج what's this?
In the axilla or groin.
discoloration ولا ايه؟
Yeah,
معناها
darkening.
discoloration.
Dark.
والاوبتيك
It's dark.
جلايوما ده بالسليت لامب
No, optic glioma of thalmoscope.
بالثالموسكوب والليش نديولس
Opt
بالسليت لامب
exactly.
ولا بالتورش عادي.
No. ليش slit lamp. Okay.
سفينويد سبليت اسمه اكسون جبون كورتكس. الكريتيريا الثانية bony lesion such as sphenoid
Yes.
dysplasia or thinning of long bone cortex.
Yeah.
دي اكس راي بقى مش يعني مش examination.
Sometimes you can find a deformity in the long bone, like the fibula down in the legs. Okay. Any other questions? Okay, Dr. Mohi, prepare yourself, your scenario, then I will have the comments. Mrs. Sarah, 45 years old, complaining of tiredness and bilateral hand pain. Please take history, examine here, and answer the concern. Okay. Plexiform, Dr. MM. Plexiform tender fibromas. Yes, it's like a collection of nerve cables, so it will be like painful or tender in examination. But you have to examine it and to take permission before examining it. I think it's against welfare to touch and to squeeze. But before that, you have to ask or offer to examine it because it's painful, as Dr. mentioned.
Like, how know which one of this is painful?
The what?
It's يعني this are multiple lesions. How I know what one of them is painful?
Is plexiform? It would be
Actually,
big
I
one.
believe
Okay.
that the deformity in the back, it could be a plexiform. Some colleagues say that it's a plexiform. So even the examiner told us not to touch
Mhm.
the back.
The back or chest?
The back and the abdomen both
Mhm.
are painful.
Exactly. Yes.
But there's a deformity, very clear, like the spinal cord inside and there's something outside coming.
Yeah.
So
It's yes,
I'm
as
not
Dr.
sure.
Yeah, it's big. It's very big one, complicated one. But the neurofibromas, the usual one or the ordinary one, will be like not big much that compared to the plexiform. I will share some photos, okay, about this to know how the difference between. Okay, Dr. Muhammad Omar, comment in renal artery stenosis raised ratio Renal aldosterone-renin ratio, you mean? In renal artery stenosis, the renin will be high, but the aldosterone will be low. So it will be, sorry, the opposite, sorry. It would be normal. It's not raised. So it's not raised.
No, I think Dr. Bassem, the renin will be high and aldosterone low in the renal artery stenosis. Renin
The
is high.
renal,
as I told
both
you
of them
before.
are high. Both of them are high. So the ratio will be normal. Why
Yes,
high?
yes.
Because the renin will stimulate the aldosterone, and it would both of them will increase the ratio. Sorry, the ratio will be fixed or normal.
Yes. Both of them high, yes.
Yes. In the opposite, the aldosterone, hyperprimary or aldosteronism, hyperaldosteronism, the aldosterone will be high and the renin will be low. So the ratio will be high because aldosterone is high and the renin will be low. It's a reflex mechanism and also it's like a cascade. So whenever the renal artery stenosis, it would stimulate the renin system to act. Renin angiotensin system will be reacted, and the renin will be high, but the aldosterone will be low. This is the difference. Sorry, the aldosterone will be high, and the renal artery stenosis, all of them will be high. That's why the ratio will be preserved or normal. But in hyperaldosteronism, the aldosterone will be high, and the feedback mechanism, the renin will be low because of hypertension. Okay, clear now? I hope it's understandable now.
Yes, clear.
Okay, vitamin D deficiency, Dr. Muhammad Jalal, osteoporosis, vitamin B deficiency. Why vitamin D deficiency? Dr. Muhammad, you can please explain.
I'm saying it's
Involvement
association, yani, but not known, but it is association. I'm saying vitamin D deficiency and osteoporosis.
due to vitamin D deficiency due to what?
Wallahi, unknown, but there is
There is
association.
association of vitamin D deficiency with neurofibromatosis or with pheochromocytoma.
Neurofibromatosis.
I'm not sure if you have evidence. Share it with us just to
Okay.
learn also. No problem. It's okay. We are here sharing the information together. Thank you, Dr. Muhammad. Involvement of neurofibromatosis type 1 almost affect the upper gastrointestinal tract and include tumors, vasculopathy. Okay, this is the explanation of Dr. Samia case. Pseudo obstruction and protein losing enteropathy. So there is association with upper gastrointestinal tract tumors. Okay, thank you for clarification, Doctor. Again, MM. Individuals with neurofibromatosis type 1 are much more likely, 25%, to develop gastrointestinal stromal tumors. Good to know this. So we have now the case and we have the explanation. But the way they are thinking is very toxic to bring a case with bloody diarrhea and to link the case with neurofibromatosis. This is not the common presentation in PACES. In presentation, they will tell you a patient with skin rash, examine, for example, unsteadiness or vision problem, palpitation, and headache, hypertension. But to present with bloody diarrhea as a neurofibromatosis association, it's very weird in the basis exam. Okay, the 10 questions, Dr. Ahmed, 10 questions after analysis the complaint and the related system is the clue for the skin lesion asking. I agree if you ask about the musculoskeletal system. Eye examination is important due to hypertension, exactly, I mentioned, for hypertension, retinopathy, and new fibromatosis itself. So you have to offer examination of the eye. Okay. Von Hippel-Lindau will be associated if there is, for example, imbalance or unsteadiness plus vision affection. It would be also association. Any question? Any place? Just ask about any pain in this lesion. Any examination, any area of the body offer examination. Before offering the examination, you have to provide, if you have any pain, please let me know. You have to say that. In case there is pain and you touch, already you asked permission earlier, so you will not breach the welfare for the patient. Take care of the welfare. Any question or suggestion before moving to the next scenario?
79 حلقة. مو بالفخر.
Okay, ready, Dr. Mahi?
Yes, sir.
Yeah. Here you go.
Hello.
Hello?
Dr. Ismail. I am senior house officer in duty now. Am I talking to Mrs. Sarah and you are 45 years old?
Yes, doctor. Yeah.
Welcome, Mrs. Sarah.
Welcome, doctor.
Today we will discuss your health issue and I will examine you and address your concern. Okay?
Okay, doctor.
What brought you to the hospital today, Mrs. Sarah?
Doctor, I feel tired these days. It started 2 months ago, but these days it's increased. I have pain in both hands. I can't carry anything because of this pain, and also I feel abnormal sensation, tingling
Okay.
sensation.
I'm sorry for that. This hand pain started with the tiredness. All are within 2 months.
Yes, increased in this. It's from long time, but increased in last 2 months.
Mm. You told me there is tingling sensation in the hand. Which site exactly?
The back of my both hands.
In the fingers or all the hand?
I feel it all hands.
All hands?
Mm.
And this tingling
In the
sensation,
back.
yeah? And the back of the hand also?
Mm. Yes.
Can you show me your hand, Mrs. Sarah?
Hand, a normal hand.
There is
But
any shiny skin, any tight skin in the hands?
no.
Any difficulty, any deformity?
No.
Only pain?
Yes, doctor, I take medication. They said to me it is nerve damage in my hands. They give me amitriptyline and para.
Any swelling of the fingers? Any swelling of the fingers?
No swelling.
Any stiffness?
No. They called me it is nerve damage.
Okay.
Like, something like
So,
this.
But no deformity. Nerve damage, but no deformity.
No. I take medication for it called amitriptyline.
So this tingling sensation in the big finger and the two beside it, is that
Yes,
right?
doctor. Yes, right.
It is more at the night?
Yes.
It relieved by shaking of your hand?
Yes, doctor, exactly.
Okay. Any wasting of the muscles?
Wasting? What you mean?
Any wasting of the muscles of the hand?
I feel muscles is normal. No, normal, but I feel pain.
Okay. What about this medication you received to this tingling sensation? It improve it or still there is?
Little improvement, doctor.
Okay. What about this tiredness? Can you give me more detail about it?
I feel tiredness over the time. I woke from sleep. I feel like I didn't sleep. Feel very tired.
I'm sorry for that.
I can't do any effort.
It increase at any specific time of the day, in the morning more, or at the end of the day, or all the time?
Maybe in the morning more. When I woke up in the morning, I feel still have tiredness.
Okay. I'm sorry for that. Do you feel headache also when you start in the morning?
Yes, doctor. Yes.
And this headache increase when you leaning forward or cough or sneezing?
No.
Okay. In the morning, you feel that the sleeping was not refreshing for you?
Yes.
Do you feel sleepy all the day, the daytime?
Yes, doctor. Yes.
Okay. May I ask you, Mrs. Sarah, any change in your weight recently?
Yes, I not. I increased in weight.
Which part of your body feel you put weight it? More in the
I
trunk
feel
or?
I feel my hand size increased and my shoe size also, doctor. I don't know why.
Do you feel that the features of the face changed than before?
Yes, yes.
Increase in the lips, in the nose, in the.
I feel my shape changed.
I'm sorry for that, Mrs. Sarah. Do you have headache as well?
Yes, I have headache.
This headache increase by cough, I told you or no?
No, back up.
Where is the site of this headache? Where is the site of this headache?
All over my head.
All over your head. Okay. What is the score of this headache from 0 to 10? 10 is severe.
4 to 5.
4 to 5. Okay. Any changes in your vision? Any blurring of vision?
No.
Do you see the road properly, the sides of the road? No, you don't bump in the objects?
No. I wear these glasses. I can see well.
Okay. Without glasses, you any problem in the vision?
Yes, I always need the glass.
Okay. Well, do you check your blood pressure before, Mrs. Sarah?
Blood pressure. Yes, sometimes it's high, but I didn't take any medication.
Did you check your blood sugar as well?
I didn't check. I don't know.
Okay. Do you feel sweaty of your skin?
No.
Okay. Any skin rash?
No, doctor.
Any change in the color of your face, of your skin?
No.
Any change in your bowel habit?
No, doctor.
Any hard motion? Any loose motion?
No.
Any darkening or change of the color? The dark stool?
No, doctor. It's normal.
Okay. Do you have any tummy pain?
No.
Okay. Any changes in your water work?
No, doctor.
What about the amount of your water work? It is increasing or the same?
It's the same.
Any frothy urine?
No.
Okay, Mrs. Do you have any past medical history that you should be aware of?
No, only this hand pain, and I take medication for it.
Okay. Do you have any surgical history before?
No, doctor.
Any hospital admission?
No.
Any family history of similar condition?
I don't know, doctor. I'm a doctor.
You are adopted?
Yes.
You are adopted?
Yes.
Show me your medication list, Mrs. Sarah.
I only take amitriptyline, and sometimes I take painkiller when I have headache.
Okay. Do you have any over-the-counter medication?
No.
Okay. Sorry to ask you this private question, Mrs. Sarah. Do you use or take recreational drugs?
No, doctor. Never.
Okay. I wanted to ask you some private question, Mrs. Sarah.
Okay.
What about your period? Is it regular?
It's regular, doctor. No change.
What about amount?
The same, no change.
Any
Average
use of
amount.
Birth control pill?
No, I don't use.
Any chance of pregnancy, either now or before?
No, no
Any
chance.
miscarriage before? Any miscarriage?
No, doctor.
Okay. What do you do for living, Mrs. Sarah?
I'm a teacher.
How much these symptoms affect your daily activity and your job?
This is affecting so much, doctor. I can't wake up in the morning because of this tiredness.
I'm sorry for that, Mrs. Sarah. We hope we fix this problem for you. Do you smoke?
Sometimes
Sometimes?
1 or 2 cigarettes per day, not too much.
You know smoking is injurious for health and I advise to stop smoking, okay?
Okay, doctor.
Drink alcohol?
Occasionally only.
May I ask you, Miss Sarah, anyone told you that you are snoring by night?
Yes, I told me that.
Okay, Miss Sarah. May I examine you while I'm taking history from you?
Okay.
I will see the hands and I see how much the hand is big, okay? Speed like
Okay.
hand. And I will check for sweating, okay?
For what?
Sweating
Mm.
of the hand, okay?
Dry.
Dry, okay. What about the pulse? Blood pressure? I will offer the examiner to check, okay?
Okay, 130/90.
Okay, proximal myopathy, is there proximal myopathy in the
Mm.
around the, okay?
No.
There is?
No.
No proximal myopathy?
No.
Okay, Mrs. Sarah, if I go back again to the hand, I will ask you only the pain, site of the pain. If you tap here or me tap here, it will induce pain?
Yes, doctor.
Okay.
Yes.
What about the thinner eminence? It is atrophied or is the same bulk of the muscle?
Average size. Normal.
Okay. What
Okay.
about the function of the hand, Mrs. Sarah? Do you have any problem using opening the jars or opening key or cope by daily activity for the hand function?
And sometimes I can't open jaws. I feel this tingling sensation and pain.
Okay. If I do abundance for the thumb with the other fingers, what about the power? It is okay, acceptable? You can, if I do circle, you do circle, I can open it easily or difficult? Intact the power of the median nerve, okay?
Yes. Yes.
Okay.
Intractable.
Okay. Then I will go to the patient, to the face. I will ask him to protrude his tongue, okay, to see how much tongue is big, okay?
Macroglossia.
Yes,
Yes.
about the lips. But I will ask him to clench his teeth to see the mandible protruded up, okay? Large nose.
Yes.
Okay, by the side, I will look to the ridge of the eyebrow. It is front big, okay?
Yes.
Then I will
Yes.
see, is there any acanthosis nigricans around the neck?
No.
Okay.
Not this.
I will see the size of the neck. It is short, and I will ask the examiner. I offer to measure the size of the neck. It is
2
short
minutes
neck.
left.
Okay. I will go to the abdomen. I will see if there is any organomegaly. Is there an organomegaly?
No.
Ask Mrs. Sarah, do you have any shortness of breathing or gasping for air by night?
They told me there's snoring.
No.
Only.
No. Heart failure symptoms, is there? Okay, I will auscultate the
No.
heart for
No.
any gallop, any murmurs,
No.
and auscultate the back for any crackles, okay?
No. No volume overload.
Okay, then I will go to the knee. I will ask him to move his knee to see any crepitus in the knee, okay?
No.
There is
Normal.
no
No.
crepitus? Okay. What is your concern, Mrs. Sarah?
Why I have this tiredness, doctor?
I appreciate your concern, Mrs. Sarah. You have a medical condition named as acromegaly. This is a growth in the master gland in the brain. It increase protein named as growth hormone. This growth hormone increase in the body weight and cause this pain in your hands, and it is also responsible for this feeling tired all the time. I want what I will do for you now. I will admit you for short time. I will run for you investigations, blood test to check the blood sugar, and I will check a visual acuity for you, visual field by telemetry, perimetry. Then I want also Mrs. Sarah to ask you. You still don't have any vision problem?
I don't have vision problem.
Okay, so because possibly you may have some problems in the vision, so I will do this test for you, because if there is an abnormality, I will ask you to stop driving and inform DVLA until we fix this problem, okay?
Okay, doctor.
Okay, time is up. You want to ask specifically for anything, Dr. Mahi? You want to do something else?
No, خلاص.
Okay,
Stop
examiner.
driving خلاص.
Okay, examiner questions.
What's your case, doctor?
My case is only acromegaly. I ask about any associated mean one. No, because no hypercalcemia, and there is no pancreatic tumors as well. So this patient also only has acromegaly, complicated with bilateral carpal tunnel syndrome, and there is the blood pressure. I want to also, and the obstructive sleep apnea with him. No symptoms of heart failure, no vision affection, and there is no blood in stool polyp. يعني there is no polyp, chronic polyp. يعني. Okay.
What's the cause of tiredness in this case?
Tiredness. Maybe because of this obstructive sleep apnea, and
Yes.
this is the cause mostly. Causing unrefreshing sleep, snoring by night, multiple apnea, carbon dioxide high, like this.
What's the mechanism of obstructive sleep apnea in acromegaly?
This
The mechanism.
macroglosia. And this weight gain also, and the main was increase the tongue size, but also become short neck and obesity. Hypoventilation syndrome can be also.
How will investigate this lady?
I will do basic investigations and specific investigation, and investigation for the complication. For specific investigation, I will check for oral glucose tolerance test. At that time, I will diagnose diabetes, and I will diagnose the acromegaly, but failure of depression of growth hormone below 2 by oral glucose tolerance test. I will also run for
what's a screening test for acromegaly before
oral
glucose tolerance?
Oral glucose tolerance.
Before the oral glucose tolerance. Before the oral glucose tolerance.
You mean insulin-like glucose factor?
Yes.
This is a screening test?
Yes, before glucose tolerance test.
Okay. I will run also all the pituitary hormones. I will do it also. And I will do it also for insulin stress factor, insulin tolerance test to check for the changes of it. Then I will do imaging also, MRI to the pituitary to assess the tumor, if it is microadenoma or macroadenoma. And I will do hemoglobin A1C also. See if there is diabetes.
What other?
You mean colonoscopy, but the patient deny any abnormality of the bowel habit and the blood. I don't know. I will ask Dr. Basim if it's indicated to do colonoscopy to see polyps or no, as long as no symptoms for this. It is screening for every 3 to 5 years. If there is, because possibly of transformation to cancer.
Yes.
How
You mentioned if
wait,
there is symptoms, Dr. Mahi, right?
If there is symptoms, huh?
Yes. Yes, if there is.
If no symptom, no need to do the test.
Yes. Continue, Dr. Mansur.
what other organs affected in acromegaly?
Other organs affected? No. Heart patient, this patient usually die from the heart disease. Heart failure is the most common cause of acromegaly.
Cardiomyopathy or ischemic heart disease?
Heart failure.
Yes,
He
due to cardiomyopathy.
has hypertension and diabetes, so possibly risk factor for coronary artery disease. But acromegaly is associated with cardiomyopathy and heart failure.
What is the main option in treatment in this case?
Surgery, transsphenoidal or transfrontal, according to the size of the tube.
If there is contraindication to surgery, what will do?
We will give medication and possibly radiotherapy also.
Okay. For obstructive sleep apnea, how will manage it?
Really, obstructive sleep apnea is difficult to control with acromegaly. We should correct the acromegaly first, but we ask him to do some lifestyle modifications, and we will help for him by CPAP or if to increase the back of the bed during sleep, like sleeping while sitting in the bed. And also there is some surgery can be done if these measures fail, CPAP and in the form of reconstruction of the throat and general surgery. I will
Decrease weight.
multidisciplinary team. He will not decrease the weight because this weight is unintentional. This is because.
But diet, they can help with diet, right? Dietitian.
Okay, but diet, if he changes the diet, he will decrease weight in this
Maybe
acromegaly.
CPAP first line in this case.
CPAP, yes.
Okay.
I finished my questions.
Yes, good question and good topic. Thank you, Dr. Marv. Now you can start comments.
comments في الهيستوري يعني good history rich diagnosis first diagnosis هي obstructive sleep apnea direct cause of tiredness secondary to acromegaly he excluded causes of acromegaly هي men ask about GIT symptoms والhypercalcemia بس في الاكزامينيشن هي missed الاي examination الفيجوال acuity والفيلد visual field I think والثيرويد also examination والsize of neck also help in في الستارت
السايز انا قلت I will offer to measure the size of the neck, but for the visual field I asked the patient many times, do you have any changes in the visual field?
But in examination also important, even you ask it in history you should examine.
If there is no time, I told him I will admit you for short hour to check the visual field by the perimetry because visual field by hand كده it will not be accurate and the patient should stop driving. So he already deny that he has any visual field problem. So this rough measurement, you see my finger like this, I think it will not be practical with him. So I will offer the multidisciplinary team to check the visual field by perimeter.
You can offer hand examination, vision examination by using your hand. It's applicable. It's okay to do that. You
How
can see,
control
yes, you can see our fingers. You can do it. Why not?
you told me 2 minutes remaining and finish one of
Yeah,
the
no,
basic
no, no.
skills.
The concept of time is different. Now you are talking about I cannot do this. No. If the time allow you, you can do even
Yes,
the vision for got it?
yes, I will.
Finger counting. It's not a matter of I cannot do it or I don't know the snail chart.
الفيجوال فيلد كان more important.
Yes, first you have to examine the acuity, then the field. He can see, okay, proceed. If he cannot see, you cannot proceed. But in this scenario, you can do the field. He might have bitemporal, but it's not in the case, but it might be associated. What else, Dr. Marwa, you want to comment?
الهارد اكزامينيشن السايت اوف ايبش كارديوميجالي.
Perfect. Why this patient might have heart failure, Dr. Mahi? What
He
we
has he has
what?
cardiomyopathy. He has
No,
cardiomyopathy.
no. It's not. What the type of heart failure? Yeah, cardiomegaly due to what? He has hypertension, right? Or she has hypertension. So this is a cause. And the other thing, it's called high cardiac output, right? High cardiac output.
Yes, it is high cardiac output state. يعني اللي هو
You have to
cardiomyopathy.
yes,
ده ليه cardiomyopathy.
yes, exactly. Okay, what else, Dr. Marwa?
بس only this I don't have.
So let's start the comment about the hand pain from the start. Did you ask Dr. Muhi? It's well done, of course, as you reach the diagnosis, but the nature of the pain, you have to ask what the nature of the pain. Is it electric like?
Yes, I ask sir. I
You
ask her
ask?
electric like more at
Okay,
night.
perfect. Okay, if you ask because it's okay. Sorry, Dr. Marwa. Just the mic. Yes. Okay, continue to the question. The other question, the scale of the pain, you can ask as well. What the scale of the pain? I think you miss.
No,
Uh,
she said about 3 to
yeah,
3 to
okay.
4.
Okay, I am also forgetting. Okay, perfect. Yes, I remember now the number. Okay. Then, yeah, I want to give advice regarding don't be judgmental question. I mean, don't tell her you have blurring vision, right? No. Do you have? Yes or no? You got it? Because I feel like you know the case and you want to judge on the symptoms she has. So you are saying you have pain while moving and it's improving. Sorry, it's with the wrist and improving while shaking, right?
Yes, I was
Yeah.
saying
So you know the case and now you are confirming the case by the question. Like, yes, answer me like, yes, it is the case. It is the case here and there. And you have vision problem. No, I don't have. Okay, you will have it soon. So don't drive and inform the. How do you judge on the future? Okay. Don't ask in this future questioning way. So if you want to ask what you have now, do you have or no? Okay. So yes, you will ask her to stop driving. But if she has the vision problem, she doesn't have now. You are pretending that she has vision
maybe
problems.
she's wrong. Maybe she's wrong. We cannot يعني we cannot depend on the patient. So we make sure. We should make
No,
sure.
no. By the way, you are not talking to a patient. You are talking to a surrogate. So either he has or she has or not. The patient, okay, some patient he will make twisted answer. Yes, I don't have. I have, but it was the surrogate informed and instructed that he will give you the answer clearly. Why? Because he will judge, the examiner will judge on your performance according to the surrogate answers or questions. So he will not give you twisted answer. No, he will not tell you, I don't have vision problem, but he has it and he want to hide it. Okay? It would be either yes or no. Just take it as advice. Don't give the question as judgmental question. You have like this. So you know the case. No, they don't like this way. They want to know from you if you can ask yes appropriate question, but by yes or no. Okay.
Okay.
Okay. The short of breath, I prefer to follow the systemic review as I prefer like chest short of breath. Yes, there is snoring. You can ask it earlier. Anyway, you catch the case and the complication also. The association you ask for parathyroid. So you want to roll out men. And this is a classical case of bases. Men or isolated. And by the way, don't say spade hand, large hand. Large hand for the welfare, I mean. And compare your hand beside the patient hand just to compare the size. Uh, what the signs of activity in acromegaly? This question from me now.
It's sweating and
Perfect.
blood pressure and blood sugar.
And skin tags. Yes.
Skin tags, yes, skin tags.
Okay. You can check for finger break marks as examination. He might or she might be diabetic, sorry, hyperglycemic. Plus offering blood pressure, the vitals. Okay. Always start by the general look. He has or she has increased facial features, for example, from the inspection. You didn't yet examine the face, but from the
I
general
examined
look.
it. I
Yes, I
examined
know,
it.
I know. Yeah, yeah. I'm, I'm telling from at the end of the bed, you can comment like this: the patient body mass index because she gain weight. You can mention she looks overweight, for example. Why you are? I'm saying that you might forget it, and while presenting the patient to the examiner, you might forget also to say this patient was or high overweight. I think you miss in the comment or the presentation that she is overweight. Anyway, the carpal tunnel, as you said, I have to offer before examining. If I tap here, there is pain? Yes or no? If she said yes, ask the examiner, may I proceed or no? Why? Because if you tap and she said yes, I have pain or ouch, it will affect your welfare. And definitely she will have pain. This is carpal tunnel case and there is compression over the median nerve, so the patient will have the pain. Better to offer, and before offering, ask here if I tap here, there is pain. Yes, proceed. If the examiner allowed, if not, tell him I would like to do tapping to confirm the. And don't forget the sensation. You didn't do the sensation, right? This is pain complaint, and the pain is sensation difference in sensation. So you can do fine and deep sensation, right? In both hand, and it would be hyperthesia. It will not be affected. It would be hyperthesia, isn't?
هيبقى هو التنجري سensation اللي في الميديا نيرف ده هو عباره عن هايبرسيزيا اوريدي
Yes,
صح؟
I mean you have to do with the sensation. Yes, by pinprick, she will tell
هو
you yes, it's
هو
high.
dermatome يعني
Dermatome, exactly. So would be in the which area in the hand, the hyperthesia?
هي هتبقى سي 6 سي
No,
6
no, no. I mean which fingers would be affected?
3.5 اللاترال
Yeah, exactly. 3.3 of the lateral fingers. So you can offer this test. Plus wasting of the muscle, as you said, and the power. And I think you did this, but try to do more power examination, not only the grip. You can ask for the function. Okay, pick up coin or button and unbutton your button or shirt. Okay, this is for the function. I think the other going for upwards, the blood pressure, proximal homeopathy, you did the face, the forehead, the face from the side. You will examine from the side for prognathism as well. Large nose, large tongue, and the opening. Yes, you mentioned already that the tongue and the mouth. Prognathism, the lower jaw, and the circumference of the neck, 16 and 17 for male and female, 17 male and 16 for female. Inches, I
اللي هو
mean. Inches.
اللي هو measuring the size of the neck يعني
Yeah,
بالتاب
yes, yes.
16 يا باشا بتقول 17
inches, yes, 16 and 17 inches. 16 for female and 17 for male. Okay, blood pressure already I checked, I mentioned, right? So check blood pressure. The heart examination, as Dr. Marwas did or said, and the apex beat, is it displaced or no? This is for the examination. Skin tags, not a skin tag, sorry, skin tags in the hand, and sweating as well. We mentioned already the acanthosis nigricans, which you mentioned already in the examination. It's perfect. Abdominal examination for organomegaly, it might be there. And one of the questions in the family history, sorry, in the systemic review about bowel change, suppose this patient might have constipation either due to MEN1, association of parathyroid, or even acromegaly itself cause constipation, right? But don't forget to ask about passing blood. It's very important, particularly if the patient is having constipation. It might be the case of cancer, colon, or polyposis. The osteoarthritis in the neck, in the knee, sorry, and last examination for leg edema. Otherwise, the history was okay. You catch the case, you ask for the association of men, and the family history here is also essential. It might be positive, but the patient is adopted. Once you have adopted in basis, you will know that it is one of the inherited condition. Specify the family history for cancer, any cancer in the family, or gland problem. She might tell you yes, hypertension and diabetes, but you can specify the question for the gland itself or cancer. Okay. Surgical history, good. The other things you ask. Dr. Marwa already mentioned the topic as investigation, management plan, and the target management and definite management, as Dr. Marwa said, is surgical. Surgical removal of the adenoma, particularly if there is compression signs. Don't forget the medical option. It's very important. What you will start with as a pharmacological option.
octreotide
Perfect.
somatostatin
Somatostatin analog. Perfect. Oh, and then
في حاجه
dopamine.
كده اسمها
Dopamine
جروس هرمون
agonist.
بيج في
Bixoman, this is the last. OCP. OCPO for octreotide, C for cabergoline, dopamine agonist, P bigvisomant, growth hormone analog, receptor analog. I think, yeah, the management already mentioned.
Doctor,
Explain, yes.
the choice will be transsphenoidal surgery. Yes, this is the first choice.
Yeah, the first
I mean
choice.
the medical.
Transsphenoidal.
Yes, if he is unfit, yes, for surgery.
If medically unfit,
Sorry, I mean the first choice of treatment in
yes,
acromegaly, the transsphenoidal
surgical.
surgery.
Yes, surgical is the management of choice. Surgery.
Yes.
Particularly if there is compression signs, means more than 1 centimeter. Oh, sorry, 1 millimeter, 10 millimeter, 1 centimeter, yes, 10 millimeter. So it would be with compression signs like bitemporal hemianopia or headache with increased intracranial pressure. Sometimes they
كنت
can,
عايز
yes,
سوري دكتور بس كنت عايز اسال حضرتك سؤال هنا في
yes,
الحته دي any there is any difference in the headache due to space occupying lesion and the obstructive sleep apnea? Both of them increase
no,
by leaning forward or no?
no. Obstructive sleep apnea is not a cause of increased intracranial pressure.
No, not causing this. يعني
Yes,
hypercapnia not increasing the pressure in the brain. So
no. It's not hypercapnia, by the way. You mentioned hypercapnia in the blood gas, but it will not be hypoxia.
hypoxia.
Only hypoxia, yes. The COPD patient are the one with the hypercapnia and the obesity hypoventilation syndrome. But this patient is having apnea because of hypoxia with no hypercapnia. Okay. This is the thing. Yeah, not increased or not a zero increase in intracranial pressure, the obstructive sleep apnea. But in the microadenoma, particularly if increased size, it might lead to increased intracranial pressure. And it might be associated with, and it come in bases. What adenoma can be complicated?
complicated with ولا
complicated by, yes, what it could be complicated.
bleeding apoplexy.
Perfect. So it comes as apoplexy, and the patient will be severe headache, hypotension with severe headache as a hemorrhage or infarction, whatever. But if there is hemorrhage, it would be a headache, severe headache, like subarachnoid hemorrhage, and the patient will be hypotensive.
Hypotensive, yes.
And he has history already of headache before. He has history of hypertension before, but now he's hypotensive. It's one of the basis cases. So take care of this. Plus the panhypopituitarism, you will find everything is low. Amenorrhea, this one you might have also, and also hypothyroidism. But it would be an acute form. So the hypertension, hypoglycemia, yes. Okay, you mentioned MRI in the investigation as imaging.
غلط ولا ايه؟
Sorry.
Yes, I said MRI.
Okay, MRI of the choice, investigation of the choice. The growth hormone screening. Let's repeat them, Dr. Mahi. Repeating the screening started by growth hormone level and insulin-like growth factor.
But دكتور الجروث هرمون يعني secreted in pulsatile manner, not يعني
Yes, it's
depends on it.
not specific. Yes, I am saying just to screen you will find it's high. It's not necessary to be the case.
Yeah, if normal also not exclude.
Yes, it's not exclude, but you can do it as initial test. If high or sky high, you can suspect the case, but you will confirm the diagnosis by oral glucose tolerance test. Exactly. And no need to mention number, Dr. Mahi, if it would be not rising more than, sorry, not decreasing less than 2. I cannot remember the number. If you are sure about the number, mention it. It's 2?
Yes.
Yeah, what? 2 what? 2, what's the unit?
مش عارف الوحدة.
Okay. Only 2. So you can say if no decrease of the growth hormone, significant decrease. So this is a case of acromegaly. I'm not sure about the number as well, but just to give a smart answer without mentioning the unit or number, it's better to avoid because maybe they will put it in the clinical judgment that you give wrong number if someone of them know the number. Anyway, this is the way how to investigate bedside. We didn't mention bedside test here. Sorry.
It is written in some books if it is failure to suppression to less than 1 microgram.
To suppress, not to raise.
Yes, failure to be suppressed.
That's why that's why if there is numbers, please avoid the numbers. I don't prefer to mention number, but it's a failure to suppress the growth hormone significantly. This is what I will mention. Okay, let's go to the bedside test. What bedside test here is important, Dr. Mahi? You can do bedside.
I said oral glucose tolerance test.
Blood sugar. Because oral glucose tolerance test, you will measure the growth hormone after the insulin.
And they will also
after the
diagnose
glucose.
diabetes. It was also diagnosed diabetes.
Exactly. So you can do a glucometer bedside. What else? Urine dipstick. Also, one of that's there. It might be glucosuria or proteinuria. What else? ECG. Do you think?
Yes, ECG indicated. Echo also needed.
Bedside tests, believe me, it's one of the
nerve conduction study for the
perfect. We didn't mention it at all, and this is the case. Neurophysiological study, nerve conduction study for the radial nerve. Oh, sorry, the medial nerve.
Sleep studying for also. Sleep study.
Yeah, sleep study. This is also one of the bedside tests. But if you start to mention the investigation as is specific or related to the growth hormone, you'll forget the other investigation. That's why I prefer to start general bedside, specific bedside, imaging, and invasive. What invasive test you can do here? As someone wrote, endoscopy or colonoscopy, sorry, at the time of diagnosis. I'm not sure about the survey program, but if there is possibility that this patient is having polyposis, he will be under the survey program, screening survey program for colonoscopy. How annual or how frequency, I'm not sure, but it would be regular. And don't try to say how frequent they will do. Frequently, regularly, and that's it. By the way, they will not ask all these deep details and questions. If you know that the patient should be underwent this screening program for cancer colon, that's enough and more than enough. Particularly if he has family history of cancer colon, for example. For how long they will not ask, because this is not for us. But if you know the answer, you can mention it. How frequency they can do it, either annual or every 3 years, every 5 years. For me, I don't know exactly what the duration. But if there is possibility that he has polyposis, the frequency will be more. Okay. Okay, I think we finished the topic. Let's go to comments. Growth hormone receptor antagonist, not agonists. Okay, thank you, Dr. Hassan. Growth hormone antagonist, big Bigfizumab. Okay. Dr. take care, Dr. Mohi, about jargon, muscle wasting. Yes, you ask the patient, you have muscle wasting. Take care about this.
دي جارجون ويستنج دي جارجون ويستنج
Wasting, you can say any reduction of your hand shape or any change of your hand shape. But wasting, this is clear clinical case, clinical word.
when I came to say the concern I wanted to say tumor in the pituitary gland وبعدين افتكرت جارجون وحاجات دي ف
No,
بعد
it's you can say overgrowth, overgrowth of
overgrowth
the master gland of your body, leading to increase some protein or substance from this gland would present with these symptoms, which you have.
overgrowth.
Yeah, overgrowth. Yeah, thank you, Dr. MM. Also, very important this comment, Wallah. I think you are helping to comment on the performance, which is sometimes I miss, but in the same time, I wanted to mention it. For example, this comment is very important, Dr. Mahi. Don't judge on the smoking level. You said, or you or Dr. Marwa said you are heavy smoker. Dr. Marwa, I think the one mentioned that. 10 cigarettes or the opposite. Anyway, don't say you are heavy or not heavy. You are smoking is injurious or harmful. That's it. I strongly recommend, or it's highly recommended, that to stop smoking. If you need some help, I can refer you to smoking cessation clinic. That's it. Don't judge he's taking heavy or not. Just tell him the smoking is harmful to your health if you have a general condition, or specific if the lungs is affected, for example, or something related directly to the smoking. Dr. Ahmed said yes, colonoscopy at the time of diagnosis to be done. Okay, I'm not sure about this program. Anyway, I think we finish. Any place just about okay. Any comment else? I think you should tell the patient his disease name in medical term. Only accepted jargon. Yes. By the way, Dr. Muhi, don't tell the patient that. Sorry, not the patient. You said to the examiner he has only acromegaly.
مستفزة دي الصراحة.
Yes, you are like you are like endocrinologist professional. I felt like also I should comment immediately, but Alhamdulillah, I remember now. So if you want to say this patient having features suggestive of acromegaly, if he asks you what else, you can say I couldn't appreciate parathyroid. I suspect men, but it's not there like this. But don't tell him it's only acromegaly. How do you know this patient might be having parathyroid with, for example, resolved or treated? Pituitary, which is not manifest, you don't know. So better to not to speak in this confident way. Yes, to be try to be confident, but don't be overconfident. It will harm also the marks for the clinical judgment. Okay, and the good thing you know that it was wrong.
المشكلة الواحد بيبقى بعد أحيانا بيبقى راجع عن الكلام اللي هو بيقوله أصلا.
Yes, I know.
كمان
Whenever whenever
بتعملوا
you are
كلام غصب عنه.
yes, whenever you are practicing different than the one commenting. So if you will comment, yeah, you will be more mature in the comments. But when you practice, you have a lot of mistakes. But with the training, you will avoid these mistakes. Okay.
Yes.
Okay. So any open discussion now? Any question? Any comment? Any suggestion? Growth hormone. Acromegaly, one of the most important topic any candidate should read before the exam. It can come any diet, any center. And the patient is okay. You can say everything. You can see everything on the patient from the first look. The same, our cases today was spot diagnosis, neurofibromatosis and acromegaly from the face. Even you can, from his face, you can know the case and try to narrow your diagnosis and differential diagnosis while talking. Yeah, we didn't mention the differential in this scenario. Of course, acromegaly on the top and men as well. And you can also put obstructive sleep apnea as association. What do you think, Dr. Marwa or Dr. Muhi? Any miss differential? Dr. Marwa, the one brought the case.
الديفرنشال لو نحطه للتايردنس يعني
Okay,
ممكن الانيميا الفاكتور سليب ابنيا
exactly.
الهارت فيلير.
And acromegaly itself as
لو الديفرنشال للاكروميجالي الكوزز بتاعت الاكروميجالي او
yes. Okay, try also to train on how to give differential. Okay. Especially differential makes sense. Don't put any differential. Differential will be, I mean, make sense. Not on every or any differential you can do. Okay. Any other questions? Comment. We can end the session. We spoke long today, 2 hours. Differential again. Yes. So as a fatigue, or let's talk about the carpal tunnel itself. We didn't talk about the hand pain in this scenario. So you can put carpal tunnel syndrome, osteoarthritis. I think also it can be associated as a hand pain in this scenario, or neuropathy.
او بريفرال
Right?
نيوروباثي.
Yes, neuropathy as associated with diabetes. Perfect, exactly. But for the fatigue, as Dr. Marwa said, the fatigue itself associated with acromegaly, it might be due to heart failure or obstructive sleep apnea or other hormonal deficiency may be associated also, like panhypopituitarism or hypothyroidism. It might be associated. Then the last differential for the acromegaly itself, acromegaly as isolated acromegaly, or you can say min type 1. It's one of the differential for acromegaly. And what I mentioned also, acromegaly min 1. And obstructive sleep apnea is the cause of hypertension and gain weight or weight gain. Any comment or question? Cancer, okay, perfect. Yes, cancer also could be the as a colon cancer, but you have to find what's suggestive of cancer, like constipation or bloody stool. You can say it's, but against that, no stool, no blood in the stool. The anemia we mentioned already, anemia for due to the cancer itself, iron deficiency. You mean? Okay, anemia of chronic disease. But sleep apnea is supposed to cause polycythemia, not anemia. So it depends on the case itself, the presentation and the symptom or the complaint. Pushing as weight gain. Okay, can be as a weight gain. Again, it's a complicated case. It's not one complaint. It's a lot of complaint. Hand pain. So you can give differential for hand pain. There is also differential for the headache, obstructive sleep apnea, acromegaly, hypertension. This is also one of the headache and differential. He might ask you, what are the differential of headache in this scenario? So hypertension, one of the causes, obstructive sleep apnea, one of the cause of the headache, and the macroadenoma or the adenoma itself is the cause of headache. So it depends on his question, the examiner question. All can occur with Cushing disease, yes. But if you want to say Cushing, you have to say against Cushing, no bruises, no petechiae, or no bruises, and easy bruises and thinning of the skin stria, I mean, and no hirsutism, for example. Okay. Any other comment or question? Okay, thank you, Dr. Nisma. Thank you, everyone. Dr. Marwa and Dr. Mohi particularly. With the attendance also all the audience. Thank you, everyone. If no question, we can end the session. Any question before ending? Okay. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.